Okay, and welcome to the Davies Use Case webinar being presented by Sparrow Health on the using health IT to promote appropriate use of blood products. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievements of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use case have been peer-reviewed to validate sustainable, improved patient business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar. First, we'll have an introduction by Chris Nimitz, and then we'll have the presentation by Margie McCloy and John Baker. So Chris, Margie, and John, I will turn the presentation over to you, and you can begin when you're ready. Thank you.
But first, I want to talk about Sparrow Health System. We're in the heart of Michigan. We have around 700 beds, 30,000 inpatient discharges, 8,000 surgeries, inpatient about 13,000. We do about 4,300 births a year. We are a level 1 trauma center. We are a 3-hospital system where we have 2 acute access hospitals and 1 long-term care hospital. We have about 60 to 70 ambulatory clinics, over 400 providers. You can see our outpatient visits. We have roughly 600,000 a year, and a variety of specialties and services that we serve the community within the heart of Michigan. And you can see several listed here, from our behavioral health to family medicine to pediatrics, urgent care, and even a wound clinic that we provide hyperbaric clinical care to our customers. So that's a little bit about Sparrow, and now we're going to talk about our program.
McCloy, the Transfusion Safety and Blood Management Nurse for Sparrow Hospital in Lansing, Michigan.
Hello, I'm John Baker, and I'm the Director of Laboratories for the Sparrow Health System.
Today we're going to demonstrate how we use IT to meet and even exceed our goals in achieving safer patient care by reducing our red blood cell and platelet transfusions. Our local problem is that we were using too much of a good thing. In other words, we were over-transfusing red blood cells and platelets to our patients. Transfusions are a procedure which we know carry a lot of risk to the patient, in addition to carrying benefit. But if they're unnecessary, it's more risk than benefit. It's also known to be a finite resource, and there are financial encumbrances to patients in healthcare facilities. Additionally, we had a lot of variation in our transfusion practices between physicians and even between physicians in the same practices. And the evidence suggests that 35% of all red blood cells are unnecessary, and 40 to 60% of all platelet transfusions are unnecessary. Before we went live with EMR, we did attempt to reduce the utilization of these products between 2010 and 2012, and we achieved only a 17% reduction in red blood cells and only a 5% reduction in our platelet use. So even though we're saying it's our local problem, the nation agrees that it's a problem for almost all hospitals. In 2011, the Joint Commission said that it was a top priority for hospitals to reduce their utilization of blood and blood products. In 2013, the American Health Association said that it was one of the top non-beneficial care procedures that were provided. And also in 2013, the American Medical Association, the Joint Commission, the Centers for Medicare and Medicaid Services all said that transfusions are overused. Anticipating that we were going to be going live with an electronic medical record in December of 2012 for our inpatient and emergency departments, we, the Transfusion Committee, and myself, the Transfusion Safety Nurse, began working with the EMR team to look at IT-enabled strategies to improve compliance with evidence-based guidelines for drug product use. So we knew that the guidelines were out there, but we were struggling with getting them to be used, even though we had them on paper. So we first focused on our red blood cell and platelet utilization. In 2012, our baseline red blood cell use was approximately 10,000 units transfused and approximately 2,500 units of platelets. So we then set our goal to reduce our red blood cell transfusions by 25% additional to what we had already reduced, and an additional 15% for our platelet transfusions. The framework we used to address the program was the patient blood management framework. And patient blood management is the term we use to describe transfusion best practice. It emphasizes a multidisciplinary approach to transfusion, and it focuses only on evidence-based transfusions and the use of single units, so try to avoid giving 2 units when 1 unit will do. And then we also had to have an approach to get blood fast from the blood bank to the bedside for our actively bleeding patients. Our hypothesis asks whether the implementation of a workflow integrated evidence-based transfusion order set while removing all other methods for ordering blood would be associated with sustainable decreases in red blood cell and platelet transfusion while giving us some financial savings at the same time. We already know that it would enhance our patient safety.
When we looked at a design process for this, we were trying to achieve some triple aims here in terms of preventing the overuse and at the same time lowering costs. And this made it a very attractive improvement effort for us because while achieving those, we could also reduce risk to patient safety since every transfusion carries risk of safety to the patient and the risk of harm. So we began with using a lot of documented evidence-based indications and parlayed this into our overall framework for this improvement project.
The evidence we used were the knowledge tools from the American Red Cross, their transfusion practice guidelines that they had published and updated recently, and from the Joint Commission patient blood management guidelines that were established. The iTool tool we used was Epic because we know that's where they were going to be placing orders. That's where orders would be acted upon, and the functions of Epic would allow us to build and use the order sets while incorporating evidence-based indications, and then the knowledge resources could be approached, and we could embed guidelines for ordering within the order set. And we believe that if it worked, we could share it with other organizations who use Epic. And it looks like I hit another slide in advance, so I'm sorry about that. But I did reach out to some other hospitals that were using the same EMR, including William Beaumont Hospital, University of Michigan, Ohio State University, and Bronson Hospital, and they were very generous in sharing their tips with us.
It was important that we, start again here, it was important for our success that we work within our governance structures, which are similar to many other hospitals. Many of these changes and particularly indications for use of the electronic medical record needed approval by the Medical Center Executive Committee. We also use the Centralized Peer Review and Quality Committee and an advisory group that's been very effective for us, the Physician Advisory Group for IT and EMR issues. All of this was guided by the groundbreaking work of the Blood Products and Safety Utilization Committee, particularly the subcommittee, as well as the laboratory and blood bank medical directors. So working through this government structure, we were able to lay the foundation for rolling out this aggressive project. Let me change that to, utilizing this framework allowed us to roll out this ambitious project.
So this diagram displays the process steps we used for the design and implementation for the order sets. So first we determined what good looks like by reviewing the literature, identifying best practices, and then, like John said, seeking the governance and developing a communication plan. Then we build the solution into the EMR by using the evidence-based order set with clinical decision support. We decided that we didn't want any standalone orders, so a physician couldn't just order a red blood cell without giving an indication or without having an order for the preparation or cross-match of it, because we had problems with that in the past. And we wanted to use the blood administration barcode safety tool that was provided by our EMR, so that it would be a check that it was the right product for the right patient at the right time with barcode use, as well as still doing the person-to-person check. And then we had to build the interface between the electronic medical record and the laboratory information system, and what we use here is SOFT. So we had SOFT blood bank and SOFT lab that we had to integrate it with. Of course, after you build it, then you have to test it and retest and educate, communicate. We had the support of the governance. Obviously, they helped with the teaching. And then finally, it was time for go live. And anytime you go live, you're always doing a process improvement, and we do PDCA for our process improvement: plan, do, check, and act for any encountered problems. The timeline is rather fluid for this project. I would say in about the first 6 months, we identified our subject matter experts. We held many meetings and discussed the content and had to come to a consensus of what we wanted in the order set. You know, a lot of people wanted to be very specific for their specialty, but we wanted this to be broad-based so that anyone ordering blood or blood products could have the ability to order it with decision guidelines embedded. So then about 6 months for building it and testing it. Another 6 months for the training, and the super user training was pretty robust. And then they went out and trained everyone else. So there was a lot of scheduling involved to get everyone included on the training. And when I say that it was fluid, I mean that even with the last go live section, we were training right up until the very end, whereas some people were training even during the building and testing aspect of this project. During go live, which was in 2013, in Q2, we gave support right on the floor, face-to-face support, and helped in any way that we could, and it went pretty well. So the actual workflow is pretty simple. The provider or physician determines that a transfusion is needed, so they log into the EMR and go to the order set or open the transfusion order set. And the order set is already defaulted to most of the things that would be needed for every transfusion. The provider could then click or unclick anything in the order set that they no longer needed. For example, if we already had a type and antibody screen, they could unselect the type and antibody screen so that they weren't reordering it. Other lab tests were on the order set, and we have the order to prepare the product attached to the order to transfuse the product. So the prepare order goes to the blood bank to tell them what to prepare and any special needs for it, and the order to transfuse is a nursing order to tell the nurse when to transfuse and how quickly to transfuse it. This is actually a screenshot of the actual order set. So this is the top of the order set, And it's very basic. You take vital signs. You have your nursing assessment, your nursing intervention, which is your education. There's the labs, the type of antibody screen. And again, they can uncheck that. IV fluids, your normal saline that's always used with transfusions. And then the bottom of the order set, we just broke it into 2 screens for you, but it's all on one continuous page in the EMR. The bottom section is the actual blood products and administration group. So we have our red blood cells to cooler, which is a method that we use to put blood on hold at the bedside in large surgical cases. We have an uncross-matched red blood cell order, a platelet order, plasma order, cryoprecipitate order, and then we have a massive transfusion protocol order. Here is an order to prepare red blood cells for the top half of the order. The blood bank gets the number of units that they want to transfuse, and it defaults to 1 unit. That helped us a lot with our blood management efforts, just the fact that it defaulted to 1 unit. And then you can see the red circle or the red stop sign is where they must select an evidence-based indication. And I'll show you what some of the indications are. Here are the most common evidence-based indications for red blood cell transfusion. And again, there are many other indications, but we listed the ones that we came to a consensus with. Later, after go live, we determined that we did need to add G, the radiation or chemotherapy patient, and then they specify what the condition is that they would need that. So for example, maybe they're getting radiation tomorrow and their hemoglobin is 8, but they know it's going to drop following radiation. Then this is the bottom half of the order. Again, it's all on the same page in the order set to transfuse. So you can see the prepare is already done on the top, very top, and transfuse. It defaults to 1 unit, and then it defaults to how quickly they want to transfuse it, whether the consent was signed, and whether to use a blood warmer. Actually, the consent doesn't default. They have to say yes or no on the consent. Shortly after go live, or maybe it was before, some questions came about how to get transfusions to the bedside very quickly for our patients who needed it now. And the physicians were thinking that that might be too many clicks to click through everything and answer those few questions. So we said, all right, we'll build a 1-click order for staff transfusions. And that is our uncross-matched order. Now, if cross-matched blood is available, the blood bank knows to give cross-matched blood, but this is a simple way for the physician to click the uncross-matched order and then not have to answer any questions about how many units, what the indication is. So they really like this, and it provided very good physician buy-in whenever they were told that they would have this for these patients that needed it immediately. So they simply sign on the click on the uncross-matched red blood cell radio button, and then sign the order, and staff ordered 2 units of blood to be prepared and 2 units of blood to transfuse. We also needed a method for our patients who were at risk of exsanguinating for getting many blood products to the bedside without needing to select every product individually. So we built a massive transfusion order, which is also 1-click, and this 1-click order orders all of the lab tests that you would expect during a massive transfusion or a massively bleeding patient, and it orders automatically 4 red cells, 4 plasma units, and 1 platelet unit, followed by 4 more red cells, 4 more plasma, 1 more platelet, over and over again until the physician determines that the massive transfusion protocol is no longer needed. We've used this and saved many patients' lives by using this formula and by having this rapid way to notify the blood bank and to allow the physicians to get to the work on the patient. order to prepare the platelets, I just wanted to demonstrate to you that it's set up the same way as the red blood cells, where it asks the physician for the indication. It's defaulted to 1 unit, and there are the most common evidence-based indications that we agreed upon to have as drop down. And then again, we added the radiation or chemotherapy for our oncology patients after go live. And then the next screen shows you, I'm sorry, the next screen doesn't show you the transfused order, but the next screen or the next portion of that platelet order would be just to transfuse 1 platelet. Another thing that we wanted to have improvements on was how we documented our blood transfusions, our red blood cells, platelets, plasma, cryo. So we asked IT if there was one spot where everything could be documented related to the transfusion, because that is one of the regulatory agency's requirements, is that everything is readily seen for each transfusion. So we determined that the blood administration flow sheet would be the best spot to document it. This is where we could do the barcode blood administration for the patient safety check, document start time, end time, volume transfused, whether or not there was a suspected transfusion reaction, and we also had a link for instructions provided by the blood bank, but there was just a link to show the RN what steps needed to be performed to complete the transfusion documentation. There are a lot of regulatory requirements for every unit that must be documented. So we were really happy that IT helped us with this portion of the effort. Obviously, anytime you go live with something, oh, here's the backtrack. Here is a little screenshot of our transfusion documentation. So you can see that pre-transfusion, they're expected to put in some answers and the respiratory status. There's also vital signs that aren't included in this screenshot, but the vital signs are there. And then on the right, I wanted to show you what it looks like whenever a transfusion is completed. The unit number is there. You can see that transfusion was stopped. The volume was entered, and this particular patient did not have a suspected transfusion reaction. So, as I started to say, anytime you develop something new, you find that you love it, but you want more. So we did have some post-go live enhancements. For example, in the second quarter of 2013, so shortly after go live, they wrote a report that listed every transfusion order, and that would allow us to monitor the transfusions and provide feedback and hopefully get improvement. In quarter 4 of 2013, we added pediatric and neonatal order sets because we started with the adult order set. They were so well loved that we included the rest of the population. In 2014, quarter 4 is whenever we added that blood on hold into the cooler order at the request of many of our surgeons and emergency department and labor and delivery physicians. And then in quarter 4 of 2015, we added an alert or a blood best practice advisory. My mind is always on blood, so that's why it says blood, but best practice advisory for duplicate orders, because we discovered that sometimes a provider would order a transfusion not realizing that it had already been ordered by one of their associates or by a resident. So this helped decrease the number of duplicate orders by displaying the last time the transfusion was ordered, the date, time, and the person that ordered it. And that cut back on our duplicate orders, which also then cut back on any overtransfusions that were occurring due to duplicate orders. In quarter 3 of 2016, we displayed lab results right on our order set, which is also very helpful. And then just very recently, 2018, quarter 3, we populated our special needs from the EPIC order, the prepare order, to the blood bank in a way that was easily visible for the blood bank scientists to see. Also, that increased patient safety. a very short screenshot of that order report that I mentioned. The actual Excel spreadsheet that is emailed to me every day has approximately 36 columns, so you can see there's only several columns here. But the columns include the patient's name, the ordering physician, the authorizing physician, attending physician, what was actually ordered, the date and time it was ordered, how many units they ordered, and then I add to this Excel sheet how many units were actually transfused. The report gives me the pre-transfusion hemoglobin and the post-transfusion hemoglobin and time, date and time of the hemoglobin or platelet or coags. So it gives me coags that I look at for my plasma orders. It gives me platelet counts for my platelet orders. It is very useful, and I would strongly recommend that you have a report written for you for someone to review daily so that you can see where improvement needs to be made. For example, if someone said the hemoglobin was less than 7 as their indication, but the pre-transfusion hemoglobin was 8.2, you would know that some education needed to be provided to that physician or provider that ordered that transfusion. What's also nice about it coming in an Excel spreadsheet is that you can sort every column. And so maybe I could look to see, well, how is that physician doing overall? Is this an ongoing problem with this physician, or is it a one-time? Or maybe cardiovascular department wants to know how they're doing. I can sort it by specialty group. So it's very handy, and I was very happy that IT provided this to me. In addition to just being able to reach the physicians whenever there are any transfusion practice questionable orders, it also helped us track and trend our pre- and post-transfusion test results, the indications for transfusion that were most prevalent, and helped me focus on who was still ordering 2 units when 1 unit might have been enough. And one great thing about the 2-unit order is we're asking our frontline caregivers, our nurses, to intervene when they see a 2-unit order for someone who is relatively stable. So let's say the hemoglobin is 6.8 and a physician orders 2 units of red blood cells. After the transfusion of 1 unit, if they're not bleeding, it is unlikely that their hemoglobin remains below 7. So the nurses have been educated to contact the physician and ask if they would consider transfusing just 1 unit instead of 2, and or repeating the hemoglobin check before transfusing the 2nd unit. And that has helped us tremendously by getting those frontline caregivers involved. I already mentioned that I can sort the Excel spreadsheet by the ordering attending physician, by specialty groups, and even patients within departments. So how do we do? Well, as I mentioned, we wanted to reduce our red blood cell utilization rate by 25% and an additional 25%. So you can see that we went live with our EMR order sets in July of 2013. And in 2013, we transfused approximately 9,500 units. You can see that each year we decreased through 2017, and that the last 2 years, 2016 and 2017, were below what our reduction goal was. So we were very pleased with that. It was working. These bars in this particular graph show that each year we reduced our red blood cell transfusions. That's what the gold bar is showing, is just a progressive decrease. The green bar is showing how we did from year to year. So even though you can see that in 2017, from the previous year, we decreased a lot, whereas 2016 from 2015, we increased a little bit. Oh, that's the opposite. We do expect that we would level out on those green bars as we reach the optimum transfusion practice. So we're very pleased with the way this graph looks. And it also, of course, saves money. So not only did we improve our patient care, we also saved a significant amount of money. Our actual cost, what the blood bank paid to purchase these units, the savings there was around $2 million. And the cost of administration that was saved is anywhere from $7 to $11 million. And the cost avoided, if you consider that the evidence suggests that it costs around $3,000 a unit, the cost avoided cumulative from 2012 through the end of 2017 was almost $29 million. Very significant. Because we had approximately 9,500 fewer red blood cell transfusions during those years, we know that we probably prevented some serious transfusion reactions. And that included at least one incidence of transfusion-related acute lung injury, which is the #1 cause of transfusion-related death. We probably prevented at least 100 circulatory overloads related to transfusion, and probably 100 to 300 uncomfortable rashes and hives that our patients experience. Platelets, same thing. We did very well on our platelet utilization reduction. Our goal, as I may remind you, was to reduce by 15%. And you can see that by 2015, we reached our goal. And even though there was a little bump in 2017, it's because we did have 3 patients who received well over 100 units of platelets alone. And it's not unlikely to have a patient receive 40 or 50 units if they're undergoing chemo or having a thrombocytopenia from some other condition. But to have them receive over 100 each did bump us up a little bit. Again, the green bars show how we did from year to year. And so you can see in 2017 that little bump. But we're still well below our reduction goal, so we're still happy with it. The gold bars, again, are showing from baseline through the end of 2017, and you can see that they decreased. So how about the savings for platelets? Platelets are more expensive to purchase than red blood cells, although they're transfused fewer, so we don't have the 28 or 29 million saving reduction, but overall we had approximately 7 million in cost avoidance. The purchase price that we saved during those years was approximately $1,350,000, and we believe that the saved costs of administration were between $2 million and $2.8 million. And there's one of our clinical laboratory scientists looking happy because he has a platelet that he can give to somebody else that needs it. With a reduction in platelet utilization, we also believe that we reduced our reactions. So there is not as much data for platelet transfusion reactions as there is for red blood cells, probably because red blood cells are utilized so much more. But we do know that there are approximately 6 occurrences or reactions per 1,000 units of apheresis platelets, which are the only types of platelets we use here at our facility. So we feel that we avoided approximately 24 febrile non-hemolytic transfusion reactions and approximately 50 urticarial reactions. We also have to look at the fact that platelets are associated with more severe reactions at times than red blood cells because of TRALI, TACO, which is transfusion-associated circulatory overload, alloimmunization, transfusion-associated graft versus host disease, bacteremia, because the evidence suggests that approximately 1 in 1,000 platelet units may have bacteria in it, and primary hypotensive reactions. So again, better patient care while reducing the cost to everyone.
We've included some capital and operational expenses here. Even though these are not new expenses to our organization, they may be if some of these program elements are not in place. And we consider these elements to be absolutely essential to the success of this program. We didn't experience any capital expenses because we relied on leveraging the pre-existing electronic medical record. Our operational expenses over the 5-year period were approximately $257,000. And again, in our institution, we already had a dedicated transfusion safety nurse, which is an important component of the program. We utilized, for part of this program, a dedicated blood bank physician or some physician hours. And we already had a pre-existing committee in place that was actively communicating. So, again, many of these were not new costs to our institution, but they may be for somebody undertaking this, and we felt they were absolutely essential. And some of the lessons learned, we did find that enforcing the use of the transfusion order sets and utilizing the EMR was extremely important, not only for collection of data, but to present the right information at the right time to the physicians. And we also found it very important to have reactive feedback to both the physicians, the nurses, and to the committee. And that was accomplished by making sure that the role of the transfusion safety nurse was, to put it any other way, protected, that this person was free to do this work each and every day to accomplish this important goal.
And I would say if we had to do it all over again, we learned that we needed to provide ongoing targeted education to our physicians and our nurses. And that was accomplished by using data reports, and we made sure that it was a consistent, frequent message to everyone. It was also really important that we had a champion on our transfusion committee who spread the word all the time, every opportunity, and actually would cancel orders if she felt that they were unnecessary, especially when we first went live. Like John mentioned, we did have a dedicated physician for blood management. Some of her hours were dedicated just to blood management before and during the implementation. The other thing that I know that was so important to the success, because we needed to have physician buy-in so that this would be successful, was to listen to the feedback that we were getting and then to respond to that feedback by updating the order sets and changing some of the things that maybe didn't work as well to make them easier to use. And I believe that anyone that attempts to do this, if they follow this process, that they could have just as much success as we've had. And that ends our presentation, and I'd like to end it on a happy note with the patient being happy that they received only the transfusion that was necessary. The nurse is happy because she or he is only transfusing what is necessary. And then we have our IT team on the side getting a constant infusion or transfusion, if you will, to help us along the way. Thank you.
Okay, I would like to thank our speakers from Sparrow Health for joining us on this webinar today, and remind our listeners where to go find more quality Davies use case webinars and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. Again, that's hims.org/Davies. Thank you and have a good day.